Here we are sharing a case of PCNL in ADPKD patient. Supine supracostal puncture was done. There were some practical difficulties and how did we overcome? We are sharing in the video. 32-year female patient, known ADPKD, had right loin pain since 3 months and CT-KUB showed right partial staghorn in the upper pole with bilateral multiple renal cysts. This is the CT-KUB showing the stones in the upper pole and in the mid pole, a partial staghorn. The patient is placed in modified supine position. The fluoro image of the stone is seen here. This is the initial RGP showing the filling defect. Upper lateral calyx was aimed. Puncture was done. Clear urine drained. Guide wire was passed which coiled into that particular calyx, and subsequently dilatation was done. Serial dilatation up to 18 French. But when we went inside the system, in fact 2 small stones also were coming out from the Amplatz sheath. The Amplatz sheath was inside a cyst, and even though on the fluoro image it was very close to the stone, we could not find the communication between this part and the stone. Therefore, flexible scope guidance was taken. Because of the supine position, we passed the flexible ureteroscope. The stone was seen, contrast was injected, and that particular calyx containing the stone was aimed for puncture. And this time, guide wire has gone into the ureter, which was also seen with the flexible scope, retrograde. Further on, we proceeded with dilatation. Serial dilatation up to 18 French Amplatz was done. And this is the picture showing the supracostal puncture just above the 12th rib. Once when we went inside, the stone was seen fragmented with pneumatic lithotripter and the fragments were cleared. Once the stone was cleared, the entire calyx was inspected, but we could not identify the communication of the upper calyx to the pelvis. We could not go to the infundibulum of the upper pole, and the fluoro image also showed a residual stone. We could not see that also. In fact, guide wire was passed retrograde and the nephroscope could not see the guide wire also. There were only clots. The stone or the guide wire could not be identified. So again we have taken flexible ureteroscope retrograde and then visualized the Amplatz sheath. In fact, the flexible scope was passed right inside the Amplatz sheath. Guide wire was passed through and through. And with this guidance, when we went in with a nephroscope, we could see residual stone, which was also cleared. So this ensured complete clearance in this patient, and stent was placed and nephrostomy was placed. So in this patient, because of the supine position, we had multiple advantages, right from puncturing the right calyx which contained the stone and avoiding the cyst puncture. The retrograde flexible ureteroscope helped, and at one point when we could not establish the communication with the pelvis, the flexible scope helped, and when we could not find the residual stone, again the flexible scope helped. So these were the advantages we found because of the supine position and ECIRS. Thank you.